Our second presentation today will be about the Pan-Canadian Health Data Content Framework, and our presenters will be Alyssa Bryan, Christine McKenzie, and Jacqueline Singer. So if you can put your videos on, I'll just do a quick introduction to each of you, and if you could wave when I'm referring to you. Christine McKenzie is a program consultant with HIE's Primary Healthcare Standards Development Partners and Engagement. She is an experienced senior business analyst with over 20 years of experience in project management, stakeholder engagement, and database management. Connecting business and IT teams together, she's led multiple projects to understand and capture business and technical requirements to create the specifications for health data exchange and database development for standardized health information in several healthcare domains. Next up is Alyssa Bryan. Alyssa is a registered nurse with experience working in critical care, public health, and community health centres. Building on the clinical skills that Alyssa acquired in her 12 years of frontline nursing, she moved into standards development for healthcare accreditation. Within this role, her focus was on developing standards on primary healthcare, palliative care, mental health and addictions, health systems integration, and cultural safety and humility. Since joining HIE, Alyssa has been focused on developing primary healthcare data content standards as part of HIE's Pan-Canadian Health Data Content Framework. Alyssa is passionate about health equity, anti-racism, and the social determinants of health, and health data interoperability. And last but not least, Jacqueline Singer is a program lead with the Primary Healthcare Standards Development Team at HIE. Hi, Jacqueline. Jacqueline has nearly 20 years of healthcare experience in various settings, beginning as a medical radiation technologist, which helped inform her later roles in administration and information management. At HIE, Jacqueline is currently focused on developing terminology for the Primary Healthcare Data Content Standard, which is a component of the Pan-Canadian Health Data Content Framework. This contributes to fulfilling one of her dreams, seeing connected care become a reality in Canada. Isn't it all of our dreams? So I'm really excited to hear more from Christina, Alyssa, and Jacqueline, and I will pass the floor over to you. Thank you so much.
Thank you, Dr. Bird. I'm going to be kicking off the presentation for our little trio, so I'm going to share my screen. All right, so today we will be talking about the Foundation for Semantic Interoperability in Canada. And my colleagues and I are all calling in from Ottawa, which is located on unceded Algonquin Anishinaabe territory. In terms of today's presentation, we're going to talk very briefly about the primary healthcare data landscape. Then we'll be going into achieving connected care in Canada. I'll be talking about the scope of the data content standard. And then I'll be passing it off to Jacqueline to talk about the value sets. And then Christine will be providing a close-up of the draft data architecture and the consultation approach. So in terms of primary healthcare data, the landscape in Canada, while we know that the majority of visits are happening, like interactions with the healthcare system, many of them are happening within primary healthcare. We have less than 1% of the Canadian population represented in HIE's EMR data. So these are just a few statistics about this current landscape with 46,000 primary care physicians. And 93% of those primary care physicians are using EMRs. There's 3 main EMR vendors, which represent greater than 50% of the Canadian EMR vendor market, which would be TELUS Health. In terms of the landscape, it's pretty complicated for a few different reasons. So first, we have the organization of primary health care within Canada is delivered across lots of different models. So we have community health centers, we have the single family doctor's offices, we have other models of team-based care, such as family health teams in Ontario. And within that data, some of the EMR data in vendor systems may be structured or unstructured, and there's a lack of standardization. I know in my practice, we often had a lot of tailoring of EMR systems to fit our practice realities, and the specific populations that we were providing services to. So ultimately, there's lack of standardization. There's a lot of different models, and there's a lot of customization and a lot of different players playing in there. So it's difficult to get a good grasp on standardized data. In terms of achieving connected care in Canada, for me as a primary care provider, connected care would mean improved care and service through enhanced people-centered approaches. There would be an increased focus on the social determinants of health. Connected care would also mean that we would have improved collaboration across sectors, and it would be informing the appropriate use of services. While we have had lots of improvements in Canada's healthcare system, we do know that there still is quite a bit of fragmentation of health information, leading to duplication of tests, unnecessary administrative burden, where providers are spending more time, filling out the EMRs and documenting than actually connecting with patients. And we have a huge issue in terms of providers and patients not being able to access the information at the right time, and lack of health system performance measurement across all sectors. So obviously this can lead to a lot of harm, but HIE is well positioned to help solve this problem. And so we're trying to do so. And what we've done in order to, or what we're doing in order to try and solve this problem, is that we have partnered with Canada Health InfoWay. We won't get into too many details about exactly Canada Health InfoWay's role, because I think they're going to talk about their role and the shared Pan-Canadian interoperability roadmap over the next few sessions that you have. But essentially, the partnership means that HIE is defining the what. So in this case, we're defining what type of primary healthcare data should be collected to inform various different things, whereas Canada Health InfoWay is doing the data exchange or transport standards. So they'll be building the technical exchange standards that enable the information to flow between the systems. So we have initiated the development of the Pan-Canadian Health Data Content Framework, and this framework has many different deliverables within it. You have the content of health data, so the data content standards. It also provides the format to capture and understand and use the information, and it enables the data to carry the same meaning for the sender and the recipient. So in addition to the standards, we also have the data models. We also have the business context model, the business glossary, and the metadata. And these are all part of the framework overall. Now getting into more of what I do within my role at HIE is really about the data content standards. So I'm going to talk a little bit about the scope of the standards and the development process that we used. So this slide really aims to demonstrate what the literature tells us about the features of high-functioning primary healthcare system. So if we're to understand what type of primary healthcare data is to be collected, we also need to understand what are the best features of primary healthcare and how it should be performing if it was optimally performing. So in terms of this top right corner, in terms of person health, person should be experiencing a person-centered approach. They should have access to a holistic set of services based on their needs. Based on their needs, they should have access to a team of providers who are giving individualized care planning and education and self-management support, all while ensuring that services are culturally safe and trauma-informed. In terms of the bottom right corner, we're really talking about the models of care that the organizations are using to provide services. So there would be an emphasis on understanding the population served by the organization, and based on that population, implementing a model of care that can meet their needs, which would include continuous and coordinated services that are accessible and effective, that are safe, and that you have a team of providers around you that have the right competencies to meet your needs. And then in terms of the bottom left corner in health system planning, what we're looking at in terms of best practice would be how primary healthcare is governed and held accountable, what their funding incentive models are, ensuring that there's an emphasis on equity and access, and other factors like the distribution of health human resources. And then in the top left corner, we're talking about more population health, people and communities. So what type of health promotion and injury and violence prevention programs there are. Again, the emphasis on equity and anti-racism, and how to prepare for emergencies or disaster preparedness like the COVID pandemic. So this is what we're looking at in terms of best practices for primary health care. And then the goal was to build a standard around those needs. So some core guiding principles when it came to the standard was ensuring that it was a person-centric approach with a multi-user design, that we were inclusive, and inclusive can mean of other standards, but also inclusive of different partners and stakeholders within the system, like people with lived experience. We wanted to make sure that we were being iterative in our development and collaborative, ensuring good data governance, and integrated with data stewardship and robust data quality. And one of the main points of driven for multiple uses and the reuse of data. So collect once, but use many times. And of course, interoperable. So the scope of the data content standard is quite broad, and this is going to be different from HIE's typical standards, or previous standards, I should say, because we're not just focusing on health system performance in terms of the data, but we are trying to define the data that would help an individual's health. So what clinicians or care teams or clients and families need in terms of data in order to do clinical decision-making and care planning. We're also wanting to include care organization operations. So what type of data is needed to support quality improvement and program planning and resource allocation. And then there is that health system use and pan-Canadian comparability, which is where HIE normally or historically has played. And then the furthest to the right is really about population and public health. So how can we help support the health of people and communities across Canada? So when we were developing the primary healthcare data content standard, we looked at, we did a giant environmental scan and looked at standards from all across various jurisdictions, as well as different frameworks to help inform the standard. So in terms of frameworks, we looked at the quintuple aim. We looked at the model for health and well-being out of the Alliance for Healthier Communities. We looked at the ISO continuity of care model. And we were also inspired by the First Nations perspective on health and wellness from First Nations Health Authority to kind of support the idea of going beyond a biomedical model of health, but to be more inclusive and holistic in the approach for the standards. In terms of Canadian standards, we looked across all HIE data content standards. We also leveraged the BC Gender, Sex, and Sexual Orientation Standard, the SPARK tool, which looks at social determinants of health and social needs. We also looked at Patient Summary Canada, the Ontario e-referral e-consult standard, as well as the OMD primary healthcare EMR standard. In terms of other jurisdictions, such as international standards, we looked at the International Patient Summary. And then we also looked at what's going on in the US with the US CDI. We looked at what was going on with the NHS and also within Australia. So all of these standards were looked at to do a gap analysis and to look at alignment across standards to understand where there were gaps in the standards and where there was alignment, knowing that we could leverage what was out there and not reinvent the wheel. In terms of how we've been iterating and refining the standard and the framework overall as we go, it's quite an extensive review process. So there's kind of this triangulation between different teams within HIE that involve the standard, the value sets, and the data models. And so this approach basically allows us to look at the standard, and then the architecture team can go about building the models that correspond with the standard. And then we look at the value sets, and then we identify where there's further gaps and where there's need for more iteration, or where there's need for the addition of data elements, to make sure that the relationships between clinical and administrative concepts are kept aligned. I believe that is it for my portion of the presentation. So I'm going to be handing it over to Jacqueline to talk about the value sets.
Perfect. Thanks very much. So next slide, please. So my portion of the presentation focuses around the terminology. So the data content standard defines both the data elements and assigns value sets where there's a codable concept. And a value set is simply a list of valid values that can be used. The values are defined by a code system, so commonly SNOMED CT, for example, which contains specific coded concepts. For example, it could be meningitis. Having defined data elements with rules around use of value sets and standard terminology is critical for semantic interoperability. In addition to the data content standard, as part of the framework publication coming in September, there will also be a business glossary, which will include more formalized definitions for these types of concepts. Next slide, please. So the value sets, as a list of values that can be used to collect data, are associated with the particular data element. And there are different sets of rules for how values can be used for a data element, which, for example, may tell you whether it's required to use a value from this set and only from this set, as well as other options. And value sets bound to data elements ensure that data is collected the same way and has the same meaning across sources and care settings. So regardless of what EMR you may use or whether you're located in Ontario or BC, we know that it has the same meaning. And this is important for both clinical data collection at the point of care and also for health information exchange. The data content standard has been designed with the collect once, reuse many times principle in mind, which means we're aligning to other key source standards that Ali mentioned previously, including HL7 FHIR, so that data can be reused. And I want to note again that we're talking about HL7 FHIR. The framework is technology agnostic. So we know FHIR is in common use, so we're referencing in development among many other standards. To support interoperability on the national and international scale, our preference is for use of pan-Canadian and international code systems. Next slide. Throughout the process of reviewing, evaluating, and recommending terminology for the primary healthcare data content standard, HIE and Infoway are partnering closely, which is true throughout various components of the framework. But specifically related to the terminology, this has been a long-standing collaborative effort where HIE typically develops the clinical facing content and validated the what in terms of what is needed in the value set. And then we work with Infoway as the National Release Center for the Canadian edition of SNOMED CT to develop the value sets. And this also includes managing the request for change process where new codes or concepts may be requested or translation so that content appears in both English and French. And I won't go into any more details here as this closely mirrors the general data standards lifecycle already shared, but want to highlight that there are different scenarios that can happen here. So again, we hope to reuse as much international and pan-Canadian existing terminology where appropriate. So we don't want to have duplicating versions of value sets in different scenarios. So we want to evaluate them together and make a pan-Canadian recommendation. In other cases, we may recommend revisions like, for example, addition of new concepts to better represent primary healthcare. And in other cases, there may be no existing value set, so we'll work to create one. And this, of course, is the most effort compared to previous scenarios where we can reuse an existing value set. Next slide. Once value set content is ready for publication, we again work closely with Infoway. They play an important role in publishing the pan-Canadian terminology content through their Terminology Gateway website. And this is a free resource available to anyone once they create an account. And I know you'll be hearing more about this during the sessions again tomorrow. HIE also publishes some pan-Canadian terminology content, for example, where there are maps from SNOMED to ICD. That's available through our website. And over the years, HIE has developed a primary healthcare minimum data set for health system performance, which also contain value sets. And many of these will be reused in the framework and appear also on the terminology gateway. So here's an example of what one of those would look like. Next slide. This is the encounter type code value set, and the value set itself has a definition. So this one's used to describe the type of contact between a provider and a client. So this is of particular interest when looking at virtual care use. And value sets have metadata like versioning and other information seen here. Next slide. If you expand the value set, you'll see the list of codes, concepts, and display names with the translations where available. Next slide. There are also many pan-Canadian terminology resources in common use, most of which are either managed by HIE or InfoWay, with some local and other terminology used within the provinces and territories as well. So for example, ICD-9 still in use for physician billing in some cases. And there's also many other standards and terminologies that aren't listed here. For example, ISO, which could be commonly used for country codes and others as well. And I, again, won't go into any details here on the standards managed by InfoWay. I'm sure those will be covered in the sessions tomorrow, but just want to highlight that, again, HIE and InfoWay have important roles in managing the pan-Canadian classification and terminology standards together. And I'll pass it off to Christine now to talk about the data architecture.
All right, thank you. So before I get started, I just want to mention I put some links in our chat about the Connected Care project, as well as the data content standard and the information model that I'm going to go over with you guys as part of this presentation. Next slide. So HIE is going to be delivering on 3 data models. And what's really important to note here as I walk through this part of the presentation is to keep in mind that what you've just heard from Jacqueline and Elisa, this is a triangulation part of our work. So this is where our data architects are working very closely with subject matter experts to develop those data elements, those value sets, as well as model the information. So at the highest level of the data models that we are delivering is an information model. And I'll talk a little bit in detail about this model in a minute. The information model will represent all the key real-world concepts that are important to a person's health and how do they relate to each other. So we say all, but we know that this is going to change over time. But for now, this is what we were able to identify. And I'll get a little bit into those details on the next slide. From that information model, we're going to blow it up into a conceptual data model, and then we're going to start to define the real-world concepts important to a person and how they relate. And we're going to organize those concepts by subject areas at a person, at a health operations, and a health system level. And then we'll take that conceptual data model and we blow it up into a logical data model. And this is where we start to add concepts to further classify and fully represent the complex relationships between the different entities and concepts within the data model. We also add on and define data attributes and elements for each of the concepts to make them more flexible and easier to implement. Next slide. So this is a very high level representation of the information model. And I'm going to start here to define what each of the layers of the information model represent before I bring up the information model itself. But what's really key here is that throughout each of these layers is that consistent data is needed in order to inform a person's health and to ensure that they have better outcomes. So at the most outer layer where we have the yellow half moon circle here, we call it the people and communities health data layer. And I want to mention that this is also mirroring those mason jars that you saw both Marie-Chantal as well as Elisa talked to earlier. So that people and communities layer, this is where we start to learn more information about the communities or within jurisdictions, no matter how you want to slice and dice it. And we start to learn more about the different services and products that might be available for a person, whether they are publicly or privately funded. For example, maybe there are some specific kinds of environmental needs assessments that's needed. Perhaps a person might need to have access to some sort of service like massage therapy. But we also start to learn about whether or not our locations where some of these services might be, if there are any wait times. We start to learn about different type of research initiatives that might be happening. For example, perhaps a consortium of researchers have gone together to develop a clinical health assessment. But no matter how you slice and dice this layer, this is where we start to learn more about the people and communities and some of the services and products that are available to them. When we get into the jurisdictional health data layer, this is where we start to learn more about the health system, about how the different jurisdictions are how the different health jurisdictions are performing within our health system. This is where we start to learn about the different products and services that might be publicly funded by a health jurisdiction. We might start to learn about what are those health human resources that might be available within that jurisdictions that are publicly funded to provide care. We might start to learn if there's any jurisdictional wait lists to receive a specific product or service. And then when we get to the red layer, which is what we call the care organization data layer, this is where we start to learn more about the organization and its operations. This is where we start to learn what kind of health human resources might be available within that specific organization, whether it is publicly or privately funded. We might start to learn about if there's any wait lists in order for a person to receive care or a specific kind of service or product within that care organization. We might learn how that organization is performing against other care organizations, or if there are any quality care initiatives within that organization, and just basic information about the organization and its location in terms of how it's performing. And then finally, within the middle, we have the person health data layer. And this is really important because we are developing a person-centric model. And this is where we learn about what information is needed in order to provide care for a person. This is where we define or we understand that it is a person that is receiving an immunization. For example, it is me as a person that is taking that medication. And when I'm in this, when I'm entering that healthcare system, this is where I would become a patient if I'm entering acute care. This is where I might be a client if I'm in primary healthcare or within a community setting, or this is where I might become a resident within long-term care. But no matter how you look at all these layers, consistent data is needed across all of these layers in order to inform and improve a person's outcome. Can we go to the next slide, please? So this is a snapshot on the data architecture, and I put a link in our chat to this information model because, as you can see on the screen, it's not quite large, and it'll be a little bit more difficult to follow along this way. But what I want to try to do is orient you to the different layers that you're looking at, and then encourage you to go ahead and have a look at the information model and what we've defined here. So in speaking about the 4 layers that I just spoke about, you have at the very top, you have the teal layer, which is the person health data layer, which we also call the micro layer. And then within the next layer, we have the red layer, which is the care organization data layer, which is also called the meso layer. And then we have the purple layer, which we call the jurisdiction health data layer, also known as the macro layer. And then within the yellow, we have the people and communities health data, which is what we also call the mega layer. Now, this is a draft version of the information model. So this and the data content center that we talked about earlier, and the links I've provided are undergoing public and open review to receive feedback. And I'll talk about that in a minute. But this time we've identified 29 subject areas. Now, if you look within each of those layers that I just spoke about, you'll see some lighter shaded boxes. Those are what we call the subject areas. And so this is what I mean by 29 subject areas. And you see them across those 4 layers. And then in the middle of that teal box is the person health data layer. And that's important because, as I mentioned before, it is a person-centric data model. And you'll notice that within each of those hollow or those lighter shaded boxes, there's a darker box. And those are the concepts that we've identified as being the key concepts important to a person's health. And you'll notice that off of each of those darker shaded areas, we have these lines coming off of them. And those lines are connecting to other darker shaded boxes within each of those layers and across the layers. So what this is to help demonstrate is that all of these concepts are interrelated. There are patterns because it is data model, and that all of those layers need to work together in order to ensure and to assist in improving a person's health and their experience. Can you click on the button? So then what we've done here, and then what I'm showing you is just a snapshot of one subject area that we've blown up into a logical data model. So the logical data model right now on the screen is for the immunization subject area for a person. And what you're looking at in terms of those darker boxes, so like the darker teal boxes on the screen, those include some of the attributes and data elements for each of the concepts that are found within that data architecture, so within those logical data models. And then when you're looking at the lines that are going off into those beige boxes, for example, over to the left of immunization and quite right underneath patient, you can see the encounter box. That beige box represents a diagram that is or represents a concept that's further elaborated in a different diagram of the logical data model. And then the pink box that you see here on this screen is just to indicate that we are aware that this concept exists, and it's something that we scope to do and work on in future. So, and what I want to really be key about is that this is just one reference model for informatics. It will include a series of logical data models that will sum up of each of those subject areas that I had just spoken about in the information model. And this, as well as some of the technical artifacts that Jacqueline talked about, such as a business glossary and some metadata, will be going out for open review later in the fall. Next slide. So now I'm going to talk about the consultation approach. Next slide. So we know that it's important that we collaborate and we work with a variety of stakeholders from a variety of different backgrounds and expertise within the healthcare system. And we know that we can't improve and help accelerate interoperability advancements if we're not working collaboratively across these different organizations and with these people that have that lived experience and expertise in order to help inform the work that we're doing. What you're looking at on the screen is some examples of the different organizations, including stakeholders such as Indigenous peoples, persons with lived experiences, care providers, our provinces and territories, and federal government. We do work with the researchers, health hospitals and authorities, as well as industries, including the vendors. Next slide. We have a multi-pronged approach to engage with our stakeholders that include the public and experts. We have our informal advisors. So this is, I like to call them our friendlies. They include clinicians that have come in and spoken to us and that we've talked to about, where we were headed, what we were thinking. They've provided some informal guidance in the development of the work that we do. This also includes other stakeholders. As you know, we work very closely with Canada Health Infoway, but as well as Statistics Canada and some other centers health organizations. We have target consultations. We will go out and talk to anyone who is interested in learning more about this work and want to contribute to it in one shape or form. We have target consultations with the provinces and territories, and we're still working across the different provinces and territories and different departments within some of the health authorities to provide overviews of the work that we're doing, but also to invite them into our work, because we really need to work with a variety of health organizations across Canada to achieve this at a pan-Canadian level. We have a series of co-contributor groups. So this is the first time we've attempted to do this, and it's been working quite well. And so we have two types of co-contributor groups. We have one for the data standards development, which includes people with lived experience. It includes some indigenous representation, as well as researchers and some standards development organizations, including clinicians. I'm sorry, my cat just started meowing. And then we are also out for open reviews. Today's our last day for open review. This is the first time that HIE has ever done this, where we've put out our draft data content standards, which include some of the value sets that we've defined for some of the data elements, as well as the information model. And we've invited anyone who are interested in coming in to provide that feedback. And then we have our Info Central working group. So as I mentioned, we work very closely with InfoWay. InfoWay has launched several product working groups for patient summary, e-referral, e-consult. They have a reference architecture working group as well. On our co-contributor groups, as well as Info Central working groups, we have representation from HIE and InfoWay that sit on both, so that we're taking the feedback that we're learning from our stakeholders, and then we're incorporating them into the products that we're delivering, including the data content that is going to be developed, that is in development by HIE. But also what's quite important about this, which Elisa talked about earlier, is that data content that HIE is responsible for developing, and that technology agnostic architecture is what InfoWay is using to develop the data exchange standards. Next slide. So I just mentioned this, I'm kind of repeating myself here, but just basically we are in an open review. We've received a lot of interest. The traffic to our web has been phenomenal, so we're quite pleased about that. We are happy to continue to receive feedback. As I mentioned, it's closing today. However, we will consider feedback ongoingly. It's just that it will fall into certain review cycles that we are going to be planning in future. And what's really important about this is that we really want to increase awareness of this work and ensure that we're providing transparency on the development and feedback process to develop the products of the Pan-Canadian Health Data Content Framework. Next slide. So here's what's next. The first version, which will be a subset of what you're seeing right now online, will be released as version 1. And then we're going to continue to expand and iterate on those versions and go out for public consultation, while ensuring that we have cohesion between our data elements, value sets, and data models. You will see in the fall as well that we will be putting out the technical artifacts, such as the logical data model, the metadata, as well as business glossary for open review and for feedback. And then we will continue to expand on the data elements that are required for primary healthcare, but we're also going to be expanding into other care domains and continue to grow the Pan-Canadian Health Data Content Framework based on jurisdictional priorities. Next slide. Oh, and that was it. Thank you. That's the end of our presentation. So I guess we can take questions.